Recording now.
Okay. Go from the start. Okay.
I'm just going to make a quick announcement while you are getting set. If you guys are logged on and you can hear us okay, please turn off your microphones. Please mute your microphones and turn off your video. I see a lot of people's microphones still on. I'm trying to go and mute you. Not that I don't think you're wonderful and I want to hear your voice, but not right now. So please mute yourself and turn off your video just so we can make sure that everybody can hear Kate. And let me know if you guys have questions. I'll be watching the chat box if things pop up.
Okay, perfect.
And
if
I do hear too many microphones, I can mute everybody, but then you'll have to unmute yourself, Kate, because it'll be trouble finding you in this group.
Okay, we'll just play it by ear, and I'll make a couple shout outs too if people are coming in and accidentally leaving their microphone on. All right, can you guys see my screen?
Yes.
All right, good. So I hear somebody with their microphone on already. So turn your microphone off. Turn it off. With like hundreds of people up here, the microphones are all on. It's gonna be hard. We might just go ahead and mute all of them just to make it easier, and then I'll unmute myself.
Sì, ci sentiamo dopo, ok? Ciao ciao. Grazie, non ti ringrazio, ciao.
I know, I'm like going through and muting.
Yeah, just mute everybody and then tell me how to unmute myself.
You just have to click on the corner of your box and where your little microphone guy is.
Okay. Yeah. Okay, so you can just go through and unmute while
Gli hai
I'm
messo un pezzo di carne.
Go ahead. Can you hear me now? Okay. All right, so all y'all are muted and now I can hear just me. So let me know if there's anything weird happening.
Yeah.
Okay. All right. So first, thank you guys for inviting me to do this. This is super exciting. I've seen the CAT classes. I've caught some of them before and they've been really cool. And I'm glad that this is a resource for everybody. And, you know, sharing stuff online is something that I love. I love teaching, especially online, but especially during this time when everybody really needs it is really cool. So thank you very much. There we go. Okay. So, nice introduction there. My name is Dr. Kate Baker. I'm a veterinary clinical pathologist. This is my dog, but we're talking about cats, so I didn't adulterate her face in this one. I actually don't have any cats right now. My husband, he's actually listening. He's driving our son around so he doesn't bother me. And so he's gonna kill me for saying this, but he's a vet too, and he also loves cats, but he doesn't want cats in the house, and I don't want cats outside, so we just don't have any cats right now. But one day, I'm working on it. But I'm a veterinary clinical pathologist. I work for Antech, which I love, and then I do a lot of teaching online in my Facebook group and otherwise as sort of my side thing because I love it. I just thought, you know, so when I was making this, the template said like accolades and awards, and I was like, well, that's boring. So let's take that out and then put in some just interesting facts, I suppose. So I was the president of the cat club in vet school. Yes. Thank you very much. I wasn't like the best cat club president in the world, but I was the president. So I feel like I'm qualified to do a cat club presentation. So I dabbled in miniature doll food making. That was a hobby. I've had a lot of interesting hobbies through my life. But when I was a resident, I was trying to think of things to do to make me a little bit of money on the side. And somehow, long story short, I ended up making miniature doll food and selling it on Etsy. Out of clay. So I actually have here's some pictures of my miniature doll food. So those are about the size of the eggs are about the size of a pinky nail and the pancakes are probably about the size of a quarter. So I have kind of always been attracted to small things, I suppose. So it goes hand in hand with my profession. I don't do that anymore, but it got a little successful on Etsy, I'm not gonna lie. And then I also love craft beer. So that's something that I recently am digging Dunkels, which is a dark German style lager, but I'm 5.5 months pregnant. So no Dunkels for me for a couple months, but I'm looking forward to being able to go out of the house, hopefully sometime soon and have a Dunkel when have a baby. This is just a fun picture of me in vet school. I know we've got a lot of vet students here, but this was my first blood draw I ever did on a white tiger. And I felt like I was pretty, badass here, but I could not hit that cat's jugular vein. And it's about the size of a hose pipe. So I remember being heckled a little bit by the residents and the exotics vet, like, okay, really? You can't hit it? It's like the size of a hose pipe. And I was like, okay, well, I think I probably should just go into pathology. So today we're going to go over 2 cytology cases and 2 hematology cases where these things are going to only happen in cats or primarily happen in cats. And they're really interesting entities. They may not be things that you see every day, but I think that these types of settings are really nice for learning about things that you don't necessarily see every day, because we need to know that those things exist also. But I'm really excited to go over these, and I'm hoping that I don't talk too much, but we'll see. We'll see how it goes. And also, one thing, I live in Louisville, Kentucky, and everything's blooming here, so I have really, really bad allergies. So if I have to mute myself and blow my nose, like, my apologies. It might happen.
I don't think anybody is gonna fault you for that. It's bad in San Diego too. I'm like just rubbing my eyes nonstop.
Yes, it's rough. It's rough. Yeah, and mine's coming with a cough, which is all making us nervous right now. So
Hashtag Corona. Yeah,
really. All right. So our first cytology case. This is a 10-year-old spayed female cat who presented with this ulcerative deep toe mass-like lesion. And you can see a picture here. This is actually not the same. I'll show the cytology. This is not the exact same case for that cytology, but it's the exact same disease process. I just borrowed these pictures from Dr. Dean. So this cat presented with this horrible looking lesion on its toe. So you can see there that that's obviously not right. There's a number of differentials that you could consider for that. Perfect. I like it. Live animation. So you can see that there's definitely something not going well with this cat's toe. And the question is, what is it? And there's a number of differentials that could go with this. I mean, you could be talking about something neoplastic, something deep infectious, foreign body that's gotten out of control. There's just a number of things. So the next thing they did is they did radiographs of this area. And you can see here on the right that there's obviously something not right there. And I do want to say that I'm pretty proud of myself because I came up with this description of the radiographs and asked my husband, who's an emergency vet, if it sounded stupid, and he was like, no, that's right. And so I just want to say pathologist still got it. So this is this like horrible swelling around this cat's distal phalanx, where it has this soft tissue swelling, obviously clearly around this phalanx, and then the tip of P3 is completely lytic. So this is an aggressive, whatever's happening is aggressive at the site of this toe. But still, that doesn't give us an answer, right? I mean, you can have a number of things even present like that. Now, this is going to make us be a little bit more concerned about cancer because there's this aggressive bony lysis. But, we don't just, make a diagnosis all the time on imaging. Not to say that imaging isn't, it's obviously very valuable, but we do need to do some additional diagnostics to get the definitive answer, which is what we're going to do. So they went ahead and they stuck a needle in it. And this is the cytology of that toe lesion. So you can see here that there are these abnormal cells. I'm going to move my little box there. So there are these, can you see my cursor? Mm-hmm. Okay. So there are these abnormal cells here, and they're kind of coming off the picture here. They're a little bit tough to tell exactly what category they fall into because we only have a few cells, and really in cytology world, we want to have a good number of cells to really get a good feeling about how they're communicating with each other. So are they individualized, or are they stuck together? Because we want to categorize every sample basically into mesenchymal, epithelial, or round cell origin. And that's the first step. Well, with this one, these actually are epithelial. They are sticking together. Again, it's just a little group, so I don't plan to completely convince you of that, but we're going to talk about how I can be very sure just from this little group. But these are epithelial. They're sticking together in these groups like epithelial cells should. And the next step is deciding if they have criteria of malignancy. and to be able to call it a malignant population, so carcinoma in the case of an epithelial malignancy. So these cells definitely do have criteria of malignancy. They have some variation in their nuclear size. So there's anisokaryosis. They're also a little bit different size cells themselves. So this one's a little bit bigger than this one. So anisocytosis. They've got prominent nucleoli here. You can see that dark color there. That's a nucleolus. That's another criteria of malignancy. So these cells look nasty, and I feel comfortable calling it a carcinoma based on that. The thing that's just really, really interesting about this is that these, well, first of all, the shape of these cells is columnar. So that's one thing to take note of, is that they have that kind of elongated columnar shape. And then what do you guys notice? Does anybody see what's happening here? And I'll just ask you guys, if you don't know, it's totally okay. But any idea what this little fringe is?
We're getting a lot of people saying cilia.
Yeah, yay. So I hope that you guys just know this, but I did post this one on my Instagram page like a couple weeks ago. My dog's getting excited too. So yeah, very good. Those are cilia. Oh, Birdie. Yeah, cilia. So this is crazy. So this is like a pathologist's dream to find this in this location. And the reason is because there's really only one area in the body that you should have ciliated columnar epithelial cells. And where do you guys think that is? Let's see if anybody comments.
Everyone's got respiratory. They're on it.
Exactly. The respiratory tract. So cilia should not be present. Is this in the, can y'all see this box?
Yeah.
Oh, you can. Oh, I'm going to move that then. Sorry. I thought that only I could see that. I'm just going to minimize you. Okay. There we go. Okay. So you can see it in all its glory. So these are cilia on these epithelial cells. And so these are really only going to be found in the respiratory tract. So why in the world are they present in this cat's toe? Well, this is why. So this is compatible with lung digit syndrome. And this may be something that you guys have heard of before, but a lot of people haven't. So it's a very interesting condition, and interesting and exciting. You know, those terms, I don't mean to be insensitive. These are things that are exciting to a pathologist. I know most of the things that are exciting to a pathologist tend to be bad for the patient. Not all, but most. So not good for the cat, of course, but a very, very exciting and interesting cytology where we have this carcinoma with, these are ciliated respiratory epithelial cells inside this cat's toe. And so the way that we connect that is that we go, oh, okay, this is lung digit syndrome. So what in the world is lung digit syndrome? Well, lung digit syndrome is a condition in cats where they have a primary lung tumor, and it's usually a bronchoalveolar adenocarcinoma that metastasizes to the distal toe or toes. A lot of times they have multiple toes affected, but it can just be one. And so this is just such an interesting pattern because it's fairly it's unique that it specifically goes to that site, because any neoplastic or malignant tumor can metastasize to other areas of the body. But in this case in particular, it has this pattern of going to the toes. And so what we want to do when we see this is we want to look for a lung tumor. The cats are usually not going to present clinical for their lung tumor. So interestingly, just like cats like to do, they like to act like everything's fine when everything's not fine. And they can have these giant lung tumors, and they come in because of their toe, because of their distant metastasis of that. One thing I will say with the cytology is that you can definitely have this condition and have the cells not have cilia. So you may do an aspirate and you see cells that look scary and like carcinoma, but you don't see that cilia. It still certainly could be this condition. So you don't always see that cilia. That's why I was so excited in this case, because there actually were cilia on these cells still. So we were like slam dunk, like that's what it is. So we recommended doing chest radiographs, obviously, in the case that we had, and then in this case they did as well. And here you go. So check. This cat has a huge caudal, caudodorsal. There you go. It's right there. I wrote this description too. Very proud. But a very large solitary lung mass in their lungs. So this makes all perfect sense. One thing too is that I've seen a case of this where the lung tumor was not obvious on radiographs, but it was confirmed that it was a pulmonary carcinoma in the toe. So there is even if you don't see that lung mass on radiographs, it may be so small that it's not showing up on radiographs yet. So it's not always going to correlate this well, but certainly in this case it did. Any questions so far?
Well, there's a few little ones. So one is there a reason why this only occurs in cats and not dogs? And then the second one is, am I remembering correctly that it most often nets to the third phalanx?
Ooh, so the first question, that's a great question because that's come up before. I've seen that actually in the Facebook group and other groups, of whether this happens in dogs. And I have not been able to find reports that it happens in dogs. I do believe that it's a cat thing. Now, may there be one in the future that is detected in dogs and then we know it exists in dogs too, maybe, or it's possible that, I mean, I haven't read every article out there in the literature, but the searches that I've done, I haven't been able to find an account of it in a dog. If any of you know of a confirmed case in a dog, definitely let me know and let the group know, because as far as I know, it's just a cat thing. The second thing, I don't know. I don't know if it is primarily goes to the third phalanx. I feel like I might have read something about that last night when I was looking at more info on this. It's possible, but I'm not sure.
Most of the case reports that I've read have been third. I think
Really?
if it extends up, if it is getting into like the second or first phalanx, it's more of an extension because it started in the third. Like it looks like it started at the bottom and worked its way up. But most of the case reports that I've read have been third. So
okay, interesting. That's interesting.
Yeah. Also, a couple questions about seeing this in larger cats or wild cats.
That I don't know. I don't dabble in wild cats, despite the picture earlier. I mean, I get mostly domestic cat samples. I have gotten like cytologies from zoo animals, but nothing like this before. I don't know about that, but that's a good question too, and I'll see if I can find any reports.
And then one more question is, does treatment involve removal of the affected toe?
Great question for somebody other than a pathologist. So everything I know pretty much ends with diagnosis. So anything with treatment is going to be something that oncologists will have to answer. I did see some posts on this on the Facebook group, in one of my Facebook groups, where they did remove the toe for palliative reasons, but with no expectation that the animal's going to have like an extended survival time because of it, but just to get it off because it hurts. But that's not my area of expertise, so I'm not sure. So don't quote me on it. One word of caution, not every old cat with a toe lesion has lung digit syndrome. So it's definitely something to keep on your radar and put on your differential list if you see this. But there are other things, like I said, that can present like this. So I don't want people giving lung digit syndrome to cats that have something else because they have a toe lesion. So here's a nice example of that. This is another cat sample that I got, and the clinician shared these pictures with me of the actual toe lesion. So it looks very similar, right? This kind of ulcerative, swollen, painful looking toe. And then they actually had taken radiographs before they submitted the cytology to me, and included that information in the submission form that this cat also had a large lung mass. So yeah, I'm not a radiologist, but it's right there. This looks very similar to the other case, right? So they had it very high, or they were very, very suspicious that this was lung digit syndrome. But they went ahead and they aspirated this toe, and that's the cytology that I got. And this is what was in that toe. So this, depending on where you live, this is very common where I live. May not be as common in other places, but what is this thing? This is a structure here that has a broad-based bud with refractile double contoured cell wall. So where my Midwesterners at and Southern U.S. people?
All your people who aren't me, because I'm a West Coast girl, are saying blasto.
Yeah, right. Good. Yeah, absolutely. This is Blastomyces. So this patient had blastomycosis right here, which is a dimorphic fungus, fungal infection, where they actually breathe this in, the infective form in from the environment, and then once it's in the body temperature, it can transform into this yeast stage, which it's no longer infective at that point. But this is often associated with lung pathology, and it can spread to anywhere else on the body. So you might be going, well, I'm used to seeing blasto lungs look like a snowstorm. That's kind of how we consider the term we use when we talk about fungal, the pattern on radiographs, fungal infections, including blasto, where it's just like this snowstorm of white. Well, you absolutely can get more nodular or mass-like granulomas. And now I've seen a number of cats in particular that have had a solitary lung granuloma that looks like a cancerous mass, but is actually blasto. And I've seen that at one case that was really interesting was when I was a resident. This cat had blasto and had this solitary lung granuloma that it was an old cat, it was like 15, and it was indoor only. And that cat had blasto, and they started treatment for it, and the lung granuloma started to shrink. So even though they never, in this case, as far as I know, they didn't aspirate this lesion. So sure, it's possible this cat had pulmonary carcinoma or a lung tumor in addition to blasto, but I mean, chances are good that those are connected, especially based on my experience of knowing that cats like to develop those solitary lung masses. And I don't have that's just anecdotal based on my experience with blasto in cats, but I think it's very safe to assume that these are all connected in this cat. I don't know the follow-up with this, so I don't know if this one shrunk. All right, that was case 1. Do we have any more questions or comments so far?
There's a few, but we've also had a request about saving questions until the end.
Okay, perfect. Yeah, I'm fine with that too. Whatever y'all prefer. Okay, so this is case 2. So case 2 is a 12-year-old male neutered cat who had an acute onset nodular swelling around his tarsus. So these are the actual clinical pictures, thanks to Dr. Feldman for sharing them, where here you can see from each aspect of this cat's hock area that it has this, you can imagine if you were palpating that it would feel, kind of firm in these more lumpy areas, maybe a little more fluidy, or a little less firm in these areas, but definitely a large and alarming looking lesion on this cat, and acutely came on. So it may not have developed overnight, but it happened relatively quickly. So they aspirated this lesion, and that's what I got. And here are the FNA results. So the first thing, that we're kind of far back here, and so we can't see the cell detail very well, but what I wanted you to pick up on is the windrowing. So windrowing is a term that we use when we are dealing with a sample that has a very viscous nature to it. So the cells are lining up in these nice rows, and you can see them best up here, where they're lining up in these rows. So hope you guys can see that.
You need to make these things.
Sorry, what, are you talking to me?
No, I just need to mute. Hold on. Sorry.
Okay. No, you're good. So they're lining up in these rows, and this is called windrowing, and this is associated with samples that are viscous, and that can include things like saliva, joint fluid, and even some tumor types like to make this kind of viscous fluid. So it's not specific to one site, but because we're right around that hock joint, this is telling me that this is associated with the joint, or they at least aspirated some joint fluid with whatever this is. And this term is kind of fun because it comes from farming, where the hay is kind of I'm not a farm girl, so I don't know the correct terms. It's like clumped together, pushed together. I have to ask my husband this every time because he grew up on a farm, and I'm like, is this windrowing or is this windrowing? Like the hay bales? I don't know. So he told me that this is windrowing, but you can see how it's the hay is all kind of lined up in these rows. And that's actually the term that in farming that they use for windrowing, or that they call windrowing, and that's what we use to describe these rows. So when we get closer to these cells, we can start to make out their details a bit better. And again, I mentioned that any cytology, specifically neoplastic processes, you want to decide if the population is epithelial, mesenchymal, or round in origin. And so based on these, what do you guys think the origin are of these cells?
I'm getting pretty unanimous around.
Perfect. Awesome. Yes, they're definitely round cells. So they do have obviously a very round shape. Epithelial cells also are usually kind of rounded in shape when you look at them individually, but epithelial cells should stick together. So they kind of intentionally want to hang on to each other. These, on the other hand, are individualized. So they're not making any attempt to stick to each other. We've got a couple that are kind of close together, but they're sort of like marbles thrown on the floor. They just end up near each other when they're like this. But the rest of these are very individualized. So we've got a round cell tumor here. And then in the category of round cell tumors, we've got 5 options. We've got transmissible venereal tumor, or TVT, mast cell tumor, plasma cell tumor, lymphoma, or histiocytoma, or some people also consider histiocytic sarcoma a round cell tumor. So out of those, and to be honest with you, round cell tumors can exhibit a lot of overlapping characteristics between each other. You would think, okay, there's only 5 options, it must be pretty easy, but it really can be really challenging sometimes to decide which one is which. In this case, we don't see any granules inside these cells, so we can feel confident that it's not a mast cell tumor, or at least some of you may be thinking, well, I know that sometimes mast cell tumors aren't completely granulated. That's fair, but in this case, the cells just don't even really have that mast cell-y look. They don't have a lot of cytoplasm that mast cells usually do. They're not a TVT. They're definitely not in the right area for that. And TVTs have really nice, discrete, clear cytoplasmic vacuoles. Now, a few of these have some vacuolation to them, but usually the TVT vacuoles are big and very discrete, where you can draw a very nice line around them. So not a TVT. So we've already eliminated 2 of them. Histiocytoma is not going to present like this, so that we can rule out. And then we've got plasma cell tumor and lymphoma. So would you guys feel like it's fair to say that this is, like, what is anybody saying what they think this might be?
I'm getting a lot of plasma cells. I saw 1 lymphocyte, but I'm primarily plasmacytoma.
Good, good. So I agree with both of those. So this is one that I would look at and go, okay, there are a fair number of these cells that look more like lymphocytes. Like they all look kind of lymphoid, whether they're lymphocytic or plasma cells. So they have some overlapping characteristics between both. Now, like some of them, like this one, you know, in this one, they have that little bit of cytoplasm. Some of these do, and probably part of why you guys are sometimes saying plasma cell is some of them have an eccentrically located nucleus. So it's kind of off to the side, which is a plasma cell thing. And then this clear area right next to the nucleus, which is a Golgi body, which we tend to associate with plasma cells. But I will tell you that large neoplastic lymphocytes can have that Golgi clearing in them as well. So it makes things a little bit complicated, because I think a lot of times we just jump to plasma cell if we see that. But if other characteristics of the cell fit more with a lymphoid population, then we have to remember that large neoplastic lymphocytes can also have that. So you have to take all the features into consideration. And this is one that's just not 100% clear. I think that the majority of these look more lymphoid than plasmacytoid. And you may be thinking, what is she talking about? No, they don't. This is just based on looking at a lot of these types of tumors. But the amount of cytoplasm that a lot of these have is quite small, much less than I tend to associate with true plasma cell tumors. And then the nucleus is not eccentric in you know, a lot of them. This one is a little more plasmacytoid than, well, it is a lot more plasmacytoid than the rest, but overall they give me more of a lymphoid vibe, but I absolutely see the plasmacytoid characteristics. So all that is to say is this feels like a lymphoma to me, but I would also mention, if I was writing a report for this, that this could also be a malignant plasma cell tumor. I hope that makes sense. A couple of cute things to point out here are these horrible looking mitotic figures. So those are not right. and should not be in this population at all. So, and one note is that remember that plasma cells and lymphocytes are related, right? So plasma cells are a terminally differentiated B lymphocyte. So there's a possibility that you're going to have some overlapping features between those neoplastic cells. Okay, so my cytologic diagnosis, based on where this was located and my feeling about how the cells looked, was tarsal lymphoma. I did mention everything I just said about how this could be a malignant plasma cell tumor, because this particular entity can be either. So it can be either lymphoma, or you may get additional testing done, that we're going to talk about in just a second, that tells you that no, actually based on the molecular markers and all that stuff, it's actually plasma cell lineage. So, but what I ended up calling this was tarsal lymphoma, and then discussed some additional testing they could do to confirm that, or to determine whether it was a malignant plasma cell tumor. So you may be thinking, well, what in the heck is tarsal lymphoma? I've never heard of that. I've heard of lymphoma, but I've never heard of tarsal lymphoma, which I got ahead of myself. I'm going to just show you the flow cytometry results on this case in particular. So they ended up doing flow cytometry on this tumor because they wanted some more information about the cell population. I don't know how familiar you guys are with flow cytometry. In a nutshell, it's a molecular test that looks at the phenotype of the cells. So it's looking at the little proteins that live on the surface of the cells, and it's trying to decide if all the proteins are the same on all the cells or if they're different. And if they decide they're all the same, that means they're clonal, so that's not normal, and that means it's neoplastic. So that's what they found in this case, homogeneous expansion of large cells. So a clonal population, meaning it's a cancerous population, and it has an abnormal phenotype. But they weren't able to find any distinguishing surface markers on it to tell exactly what type it was. So they couldn't say, this is, lymphoma, this is plasma cell, this is some other type of crazy hematopoietic tumor. But knowing everything we know based on how this is presenting and everything, we still feel comfortable that this is either lymphoma or plasma cell. This just didn't end up giving a lot more information. So they did actually end up submitting some tissue for histopath for this, and got some special stains done with that determined that this one actually was a lymphoma. And it actually interestingly was T cell, which I won't get into all the details of that, but that is interesting because with those lymphomas, I just mentioned that a plasma cell is a terminally differentiated B lymphocyte. And this one had some plasmacytoid features, but it actually was a T cell lymphoma. So kind of weird. So what is tarsal lymphoma? Here's a paper where they looked at cutaneous lymphoma of the tarsus in 23 cats. And this is such an interesting clinical entity that we can see in cats, where they develop this focal lymphoma. I mean, it's predilected to that tarsal area. I have seen a few cases where it's around the elbow as well, but the majority of the cases that I've seen have been all right around that tarsus. So in this paper, they looked at whether it was associated with retroviral status, and they found that there was no association with retroviral status. The median survival time, unfortunately, was only 190 days. So not long. And that in this study, they had a variety of treatments associated with that survival time. So it varied from no treatment at all to like extensive chemo, and that was the median survival for all of them. And they did find that the majority of these were non-epithelial trophic and of high grade. So that's high grade is not good. And then they did find that there was systemic involvement. So these neoplastic cells can go into other places. So even though you see them right there around the tarsus, they can go to the spleen, liver, bones, chest, or lungs, and specifically the popliteal lymph node. In this case, did have popliteal lymph node involvement. So it's good to do staging in these cases if you have a case of this. I actually talked to a vet just this morning about a case of this. He has a cat that has this. So follow-up in this guy, he did have popliteal lymph node involvement, but they didn't do any more staging on him aside from aspirating that popliteal lymph node. He was put on prednisolone, and he actually had a leg amputation done for palliative reasons, but unfortunately he was euthanized 4 months later because he had developed neurologic signs. So everything in his case really fit with this study. So he lived about 4 months, and he did have systemic involvement. All right. So that was tarsal lymphoma. Again, it's not a super common thing, but it definitely happens, and it's good to keep on your radar if you ever see something like that.
That was very satisfying for some
Good.
reason.
Good.
The slides are like, oh man, that was really satisfying. I don't know why.
Yay.
Most of the questions that were coming through, you kind of already covered it. So kind of follow-up diagnostics, therapy, things like that. There was an immunohistochemistry question, but then you had the flow cytometry slide. So
yep. Yeah, and the immunohistochemistry was done on that histopath sample that they had submitted, and that's how they had decided that it was a T-cell lymphoma.
I'm so intrigued by the T-cell thing. Like, that really
I know.
Nerd brain. Oh, okay.
I know. I was really surprised too, because, and that's actually a really good point, because when you do look at a lot of cytologies and you start looking at lymphomas, you may see that pattern where you see these big blastic, ugly round cells that look like large lymphocytes, and you see that little paranuclear clearing and think, oh, it's probably a B-cell lymphoma. This is an excellent example of how we cannot phenotype in the majority of cases, with very few exceptions, based on cell morphology. So we need to get, even if we have a hunch, or there's some cases where there may be a more consistent pattern with that particular type of presentation or whatever, that are more often B or T cell. This is just a really nice example of how we need to do additional either IHC, ICC, so that's immunohistochemistry, immunocytochemistry, or tissue flow cytometry, those additional testing to tell us whether it's B or T cell, because based on the morphology alone, it's not always reliable. All right, great. So this is our first hematology case. So those were the 2 cytology cases I wanted to go over. And then these are the 2 hematology cases. So in this case, this was a 5-year-old male neutered cat who presented on ER for profound lethargy. And he actually was a technician's cat at our hospital and presented to my husband, who was working on ER that day. So on physical exam, this cat was quote unquote a flat cat. So he was really, really, really sick, basically profoundly lethargic, and just, what's the word when they're on their side, or they're just not moving very much. I don't know all those.
Lateral recumbent.
Yeah, there you go.
Unwilling to be a part of this world at this current moment in time.
Right. Exactly. Y'all get it. So all of those things. So he was just super, super, super sick. He was hypothermic, so he was so ill and kind of heading down that dying path that his temperature was actually low. And he was very yellow. So he was yellow as the back of this cat's picture. And interestingly, he actually had oral petechia, and my husband had mentioned that he had never seen, he's been in ER for a while and he's seen a lot of cases, but he's never seen petechia in a cat. So it's just not a very common thing to see, I suppose, but very interesting. Yeah. Okay, good.
Practitioner. Yeah.
I was sitting there thinking, what if they say, oh, I see it all the time? I'm like, well, you have a weird, presentation of cats then. But yeah, so very unusual. So the first thing that they did was they ran a CBC. And here's what we see on our CBC. And we can see that there's a moderate non-regenerative anemia, because we've got a normal reticulocyte count here. So it's non-regenerative at this point. It may develop a regenerative response within a couple of days. It takes the bone marrow a little bit of time to develop a regenerative response, but this, at this point, there's no evidence of regeneration. There also was a neutropenia, quite profound, and a profound thrombocytopenia. So his platelet count was reading at 0 on the CBC. And what I hope you guys all know is that we don't always, we really should never trust our analyzers completely with all our hearts, but definitely when it comes to platelet counts, in especially in cats, because cats love to clump their platelets, and they can be really low and actually be normal when you look at the blood smear. So you always need to check a blood smear to make sure that that's correct. In this cat's case, because he had petechia, I mean, I feel like we can trust that he definitely has a thrombocytopenia, is probably quite low because he has clinical signs with that. And then, so with this together, the anemia, neutropenia, and thrombocytopenia equals pancytopenia. So that's a term we use to describe when we've got all three of these things. This is separate, so this does not count as a pancytopenia. This has nothing to do with pancytopenia, that term, lymphopenia and eosinopenia. So his lymphocytes and his eosinophils were also low, but what is that from? Anybody know?
I'm waiting. Bueller. There we go. Stress leukogram.
Perfect, perfect.
Yeah.
This is a stress leukogram, so I don't care about that. What I care about is this. This is bad. So this suggests that there's something going on that's severe, and usually that suggests that there's something going on in the level of the bone marrow. But we wanted to look at a blood smear to see, you know, if we could find any clues to give us an idea of why this cat had this. So this is what we see on the blood smear. One thing I'll point out is that my slide was a little bit dirty, so all these little specks everywhere we just have to ignore. So that's just debris. But does anybody see anything in these red blood cells that could explain what this is? What's going on in this cat? And I've got a, you know, obviously the clue here, but what is this?
I know, I'm waiting. We have one vote for potential artifact. We have a hemo, a myco. There they start rolling in. We have a lot of mycoplasmas, a lot of parasites.
All right, y'all are on the right track with parasites. It's definitely a red blood cell parasite. It's not mycoplasma. So mycoplasma is going to be a little blue, solid blue dot that lives on the outside of the red blood cell. So in this case, I mentioned I've got some debris here that we just need to ignore. It's like black color. It's not the right color for mycoplasma either. But the organism that we're seeing that's of concern are these guys. And it has this signet ring appearance. So it's got this blue dot and then this little ring shape around it.
So we've got a lot more. We've got some other infectious diseases. So I have a lot of hepatozoan, a lot of cytauxzoonosis, a couple babesias.
Awesome. Yep.
So I was like, they're getting close. They're getting really close.
Yeah, you guys are getting warmer. So hepatozoan is a giant, like pill-like structure that lives inside neutrophils and monocytes. So not hepatozoan, but you're on the right track with a zoan. So this is cytozoan. So cytozoan looks like this. And we're going to talk about babesia in a second, because that's also not wrong. But we do not have babesia where I live, babesia felis, that is. So this is not babesia because it's just excluded because of a geographical. So this is consistent with cytozoan. So cytozoan felis. I know that this is not something that everybody's going to have everywhere they live, but I thought it might be a cool case to show because one, it emphasizes the importance of a blood smear in your cases. And two, it emphasizes a cool case that maybe you'll never see, but it's fun to learn about. So cytozoan felis is a protozoal infection. It is tick transmitted. So this cat had ticks at some point. This is why tick control is very important in cats as well. He was an indoor-outdoor cat, so that explains how he was getting ticks. And in our area, the bobcat is the asymptomatic reservoir host. So the ticks feed on the bobcats, and then the tick jumps off the bobcat and hops onto our domestic cat. The bobcat is completely unaffected by this usually, but the domestic cat cannot handle this. So this is a horrible disease to have in a cat, in a domestic cat. The vast majority of these cats are gravely ill. So they are on their last leg. And even with really aggressive treatment, they don't usually survive this. Now I will say with really aggressive treatment, there have been some studies lately that have, and again, treatment's out of my realm of expertise, but my husband has updated me on this. There have been some studies that have suggested or given kind of a little bit more hope for these guys if their owner's willing to go all in and do feeding tubes. And there's 2 antibiotics in particular that these cats need. They need really, really aggressive treatment to even give them a chance, and they still might die. There are a couple there's some anecdotal evidence at this point that there are some less virulent strains of this particularly in Arkansas, where the cats have this infection but aren't always clinical for it. So that's just another thing to consider as well. But usually they're very, very sick. If they're going to get sick, they're going to be really sick. Unfortunately, this kitty cat was euthanized. I mean, he was about to die anyway, so he didn't make it. So a couple of you mentioned Babesia, and I love that because Babesia felis is something that you should consider if you live in South Africa. So I hope we have some South Africans here in the talk, because I know that we were hoping that we could get all six continents.
Yes, we do. We have South Africa and Egypt.
Oh,
So,
nice. Cool.
A couple ends of Africa, all 6 continents today.
Yay, yay. Awesome. Way to show up, team. So, so yeah, if you live in South Africa, you should also consider Babesia felis. And I'm pretty sure it's on the coastal areas. But that's pretty much the only place that this is really going to be considered. They look very similar as far as I know. If anybody knows of anything emerging, you know, things are changing all the time with infectious stuff, then pop that in the comments.
We have a comment that it is common in Egypt as well.
Oh, okay, good. Well, that's very good to know, because the literature at this point, unless there's something recent, just talks about South Africa.
Cool.
So that's good to know. But these look very similarly. This was a report that came out in Vet ClinPath that have that signet ring appearance to them too. So you have to consider that as well, but we don't have that here, so it's not going to be a consideration. Okay.
Somebody says Malaysia as well, and one from Portugal, but those might be Canis.
Yeah, so that's the thing, is that make sure that you're not confusing Babesia canis, because Babesia canis is very common in lots of different countries, including in the United States in certain areas. But Babesia felis in particular is not. At least it's not in the literature.
Okay.
All right, great. So that was the third one. I debated whether to put this fourth case up because I was afraid I was going to run over time. But I think I'm doing okay on time.
Yeah, go for it.
All right, good.
I don't think anybody will be upset with you.
Okay, good. I just felt like a nice round number to do 2 and 2. So this is the second hematology case and the last case that we have. This is a 6-month-old female spayed kitten. I'm going to take a quick drink of my water because I get overexcited and I start panting and refreshing. Okay, so this was a kitten that presented for lethargy. And then on exam, this kitten had pale gums. So there wasn't a lot going on the exam or specific on the clinical history, but detected some pale gums. So they did a CBC as the first step. And what they saw on the CBC was that there was a marked non-regenerative anemia. Honestly, I don't remember the exact number, but it was in the teens of the hematocrit being in the teens. So very severe. And this cat also had significantly increased nucleated red blood cells. So what do nucleated red blood cells typically insinuate in relation to an anemia? I'll give you all a second to respond.
Getting regeneration from most people.
Great, perfect. You guys are smart. So regeneration is what that usually correlates with. So when we see increased nuclear red blood cells, that makes us at least feel like this may be regenerating at this point, or that may be associated with regeneration. There are certainly some scenarios where nucleated red blood cells don't correlate. So like you might have a case where you have increased nucleated red blood cells in a non-anemic patient, and then there's a whole long list of why that can happen. But when it's associated with, when an increased nucleated red blood cell count is associated with anemia, it usually makes us think about regeneration. So even though on this CBC, the reticulocyte count was normal, or was not, the reticulocyte count was not increased to suggest regeneration, we did have these nucleated red blood cells. So if you're just looking at the CBC, you might think, oh, well, maybe it's regenerating. But this is why the blood smear is so, so important, because the whole story is not going to be on your analyzer, and the analyzer can only do so much. So the next step was that we looked at a blood smear. So here's just a small snippet of the blood smear, and I tried to pick the most representative area that gave the most clues. But this one picture like we really want to look at the whole blood smear and really get a good, you know, it's putting a puzzle together. So we want to get a good idea of like what all the cells really look like. But this is pretty representative of what was all over the smear. So here you can see there are nucleated red blood cells. So they've got this nice perfectly round nucleus and this nice like kind of bluish red cytoplasm. Sometimes people get confused with lymphocytes with nucleated red blood cells, but they shouldn't have this color cytoplasm, and they just look like a little bit different than lymphocytes. But don't feel bad if you ever get those confused, because even your machines will get them confused. So sometimes your machines will call nucleated red blood cells lymphocytes. So again, another reason we need to look at the blood smear. So okay, so there's some nucleated red blood cells here. But then what are these? What are these doing in here? These 4 cells, these are not normal. So these guys are like, no, no, no. You guys are not supposed to be in this blood. And the way that I would describe these cells is blastic. So the reason I'm calling them that is twofold. One, they're huge. So these guys are really big. This cell here is kind of falling apart. It was probably a monocyte that's just falling apart. Yeah, because its nucleus is kind of big, maybe a neutrophil, but its nucleus looks more monocyte-y. But so you might say, well, those kind of look like lymphocytes because they're kind of big and have like a little bit of cytoplasm. But even if that were the case, lymphocytes normally in the blood should be smaller, about the same size to smaller than a neutrophil, and like a normal small lymphocyte. Remember that monocytes are even bigger than neutrophils, and these cells are even bigger than monocytes. So these are gigantic. Then you might say, so that's the one thing. It's blastic because it's huge, and then also because they have these prominent nucleoli. So I can see this clear space with the ring around it here. These here are nucleoli, and they're really big. And so that tells me that this is a blast. And a blast is an immature hematopoietic cell. So blast can be either myeloid origin, where those develop into the different types of red blood cells and white blood cells, or I'm sorry, let me back up. Myeloid origin differentiates into our red blood cells and like our granulocytes, like neutrophils, eosinophils, all that. And then our lymphoblasts develop into our lymphoid lineage, so our T, B cell lymphocytes. So blasts of either origin are going to look the same in most cases. So you can't really tell if they're myeloid or lymphoid lineage in a lot of cases. Sometimes you can pick up a little bit of clues. So in this case, and you'll have to trust me because I don't have an example here to show against it, but this cytoplasm is more blue than lymphoblasts typically are. Now, lymphoblasts can be this blue, so it's not that it's impossible they're lymphoid, but I'm thinking these look more like what I kind of expect erythroblasts to look like. So blasts that are of the red blood cell lineage. And this, combined with the fact that I have these nucleated red blood cells in such high number, really make me concerned about one particular entity that can happen in cats. It can also happen in dogs, but it's more oftenly seen in cats. Does anybody, I don't feel like I really framed that question well, but I'm trying to get you to go at one particular type of neoplasia.
I'm just waiting a second. I have one AML question mark.
Good.
A couple leukemias.
Yeah. Yeah, great. So that's all right. So this is, when we see this combination of these big blastic cells and then these nucleated red blood cells that one other thing about this is that there are nucleated red blood cells in here, but the reticulocyte count was normal. So that's abnormal, right? Because really it should go hand in hand. If you have this like super high nucleated red blood cell count and a reticulocyte count that's normal, that does not fit. They really should go hand in hand. And so that makes me go, And then I look at the blood smear and I see blasts in combination with that. I'm thinking erythro leukemia. So specifically an acute myeloid leukemia of the erythroid lineage of the red blood cells. that is affecting this animal. And that's what this is. So this poor kitten has erythro leukemia. And you might be going, well, what in the heck? It's 6 months old. How can that be? Well, there's a scenario, there's a certain infection that is more often associated with erythro leukemia in cats. Does anybody know what that infection is?
I'm waiting.
It's okay. I can wait. I can take a sip of my water. It's a type of virus.
So I'm getting FeLV.
Awesome. That's right. Yeah, perfect. So FeLV, there is a correlation between this type of leukemia in cats and FeLV infection. Not every cat with erythroleukemia is going to have FeLV, but they often are associated with each other. So anytime I see a pattern like this, I'm going to emphasize the need to do FeLV testing and FIV as well, because FIV can do some weird stuff, but this is usually an FeLV thing. So they did on this cat, and lo and behold, FeLV positive. So this all makes sense. So in this poor kitten, this cat has this erythroleukemia induced by FeLV infection. Now, the little asterisk there is that, without getting into too much detail because it gets a little complicated, there's a condition called myelodysplastic syndrome that is not quite leukemia, but it's stuff's going weird in the bone marrow. Things are not maturing appropriately. You end up getting pancytopenia in a lot of those cases. It's not quite neoplastic at that point, but things are not right in the marrow. And that also can happen with FeLV infection, and you can get some weirdish cells out in circulation with that as well. So sometimes in these cases, you end up having to do bone marrow exam to get more information, to confirm a diagnosis if you're not sure. You know, if I only saw like 1 blast or 2 blasts and, you know, it didn't have a lot of blasts, I might be hedgy, but, and suggest bone marrow exam, but that's going to be case by case. In this case, there was enough evidence in the smear itself that I felt comfortable calling this a leukemic process.
We have a couple questions.
Sure.
So question number.
Oh, you cut out.
Relation 5B.
Oh, wait, you're going to have to start over. Sorry, you cut out for a second. Hold on. Okay.
Yeah.
Can you hear me now?
Yes, I can hear you.
There you go.
So it's one of the questions is there a correlation between that erythroleukemia and FIV?
So good question. FIV can do weird stuff in the marrow as well. To my knowledge, it's not associated specifically with erythroleukemia the way that FeLV is. FIV can cause, and like a lot of us, you know, have probably seen before, certainly can cause hematopoietic neoplasms to occur. So it's a lot of times associated with tissue, like lymphoma, like out in the tissue. But this particular entity is more of an FeLV thing.
I would agree with that from a practice standpoint.
Yeah.
Most of my FIV patients live very long, unexpected lives, which is good. But if I do see them, it's going to be a lymphoma. Yeah,
exactly. And FeLV, they can. I mean, we all know they can live with that as well. But when this happens, you know, they're not all going to get this, but when they do, it's not a good situation.
And then there's also one more question about how are those blast cells often counted on the procytes in the dot plots?
Really good question. So on the analyzer, a lot of times they're going to count those as lymphocytes. So again, another good reason to look at a blood smear, because kittens get mild to even moderate lymphocytoses all the time. I mean, any cat, you know, a cat's spooked in the clinic and it shoots up its lymphocytes because of an epinephrine response. And you might go, that's not a big deal. It's just a mild lymphocytosis. But then you look at the smear and there are all these horrible blasts. Like, so usually they'll count them as lymphs.
All right. It looks like most of those questions are getting answered. There was one question about testing for FeLV in cases like these. I'm an advocate of like every cat that walks in my hospital should have an FeLV test. Like you're not getting a good database unless you test them, but especially the sick young kittens, for sure.
Yeah, and I think that's a fair question though, if kind of what they're getting at is, you know, we have an answer, like what's the point of spending more money on a test? I get that. I mean, we've got a neoplastic process happening. I get that. But at the same time, if they live in the same house with another cat, I mean, you really want that information for the owner, you know, to know to test the other cat. I think that's pretty valuable as well. So, and it helps put everything together, but I understand it's not always possible.
That's good.
Any other questions?
Oh, don't.
If there are any, then I'm more than happy to answer them like by email or just however, you know, and I'm about to show you guys how to get in touch with me here in the next slide. So that was fun. I hope that wasn't too much. Again, sometimes I get a little bit excited and go a little fast, but I think we're doing okay. Couple of learning opportunities if you guys are interested. So one thing is, Dr. Marshall had mentioned my Facebook group. So if you're not in the Facebook group and you're a veterinary professional of any kind, so you're in vet med in some capacity, which I'm assuming all of you are, then go request to be in the group. Make sure you answer the questions. Otherwise you won't get admitted, because we get like 50 plus requests a day. And if we don't have time to look and check your profile. So make sure you answer the questions. So go join the Facebook group. And then starting on Monday, April 27th, I'm going to be doing a free workshop in the Facebook group where I'm going to do daily little mini classes, usually 15 to 20 minutes long, about different hematology topics. And they're going to range from more basic to a little more advanced, but it's appropriate for everybody. So students, technicians, veterinarians, veterinary specialists, everybody that looks at a blood smear. So that should be really fun. I'm really excited about it. So go request to be in the group, and then to sign up for the workshop, you can go here to this link, www.veterinarycytologyschoolhouse.com/workshop, and put your info in there, and then you'll get like email reminders and stuff about it and what we're doing every day. You don't have to do this sign up. You can just log into the Facebook group and it'll be live every day at 9 p.m. Eastern time. But I know a lot of you are not on Eastern time, and that might be like the middle of the night for you. So I am going to be recording it, and I'll send out information about how to listen back to the recordings if I have your email. So make sure you go there and put your email in there.
That's wonderful.
On my website, I also have the courses. So I know a lot of you are looking for race approved CE because a lot of the conferences have been canceled. I have a couple of course options if you're interested. Cytology 101 is a free 30-minute mini course, and then Mastering Cytology is available now for 5 race credits, and my Mastering Hematology is actually going to be ready next week. So I'll give you all more information about that too, but those are some options for continuing education. And then here's all my social stuff, because I spend too much time on my phone. But I love it. So this is my jam. I love teaching. I love getting involved with people, especially on the Facebook group, and talking about cases and everything. So if you want to join, then do. But I think that's it.
This has been fantastic. Thank you so much for connecting with us.
Yes.
If there's anybody that's still out there that didn't get to register their country or their university or the state where they're practicing, you still have time to add that to the chat. We had, that I counted as they were scrolling by, we had 20 of our US universities,
Awesome.
and 24 countries, 6 continents, that I might have missed some, and only I think only half the people or less put down their affiliation. So that's awesome.
I love that. That's one of my favorite parts about all this, is just connecting with people all over, and you know, we're all in a really weird time like right now. So
Yeah.
sharing all this is really great.
That's what I've been telling my students, is I teach 2 days a week, and I'm like, the world is weird right now. Like, we're just rolling with it. We're just doing what we're doing.
Exactly. Like, I'm in my house. Like, this is where I live, you know. This is just it. So, you know, it's great. And I really appreciate being invited to speak and come talk to you guys. This is so fun for me. If you, I mentioned my email, I didn't put it on here. If you guys have any questions specifically for me, you can either go to my website and there's a form in there that you can talk directly to me. It just goes straight to me. Or you can email me at kate@cytoschoolhouse.com. So I'm very open. I'm happy to answer anything or talk about anything. I mean, not anything, you know. But
So
those things.
those radiology questions, shoot.
Right. And like some personal stuff, you know, I'm pretty open book, but like, don't, we'll keep things, private.
Well, this is great. You're probably going to get a lot of questions.
Sure.
And I've just been thrilled. Thank you to everybody that joined. And
Yeah, thanks,
even
guys.
if you're just big Dr. Kate fans, if you're interested in other cat stuff, we've got, let's see, Wednesday, we've got the diabetes. So we're going to talk about that. That'll be good. And then Friday, we're coming back around to more dentistry because we just couldn't fill it up from last Friday. And then we're still looking at stuff for next week. That's a little bit open. I think one of the days we're probably going to just do a ask anything about cats or anything about vet school or life or whatever, and just kind of open it up a little bit more social, a little bit more not structured, and we'll see how that goes. So I think that's all we have for today.
Okay.
This has been fantastic. Thank you so much,
Good.
Dr. Baker.
Good. Yeah, thank you everybody for coming and spending time, doing this. I know I went a little over, so I really appreciate that. So great.
No problem.
Awesome.
You're a lot more brief than Dr. Rongren whenever she's talking. So
as long as I'm somewhere in that realm.
yeah.
I'm right there with you. All right. Thank you guys.
Thank you. Bye-bye.